this education program today, we will review the current treatment and diagnosis of multiple myeloma. So we will use a didactic case and then several scenarios based on the script concordance. The learning objectives include to examine how to recognize patients in the early stages of multiple myeloma, to explore available options in managing these patients, and also to exchange ideas with experts on the best treatment options using the script concordance methodology. We will present a patient with a possible diagnosis of multiple myeloma. Multiple myeloma is an aggressive malignant neoplasm of plasma cells which accumulates in the bone marrow. It is the second most common hematologic malignancies, and approximately 15% of all hematologic malignancies are due to multiple myeloma. The incidence of multiple myeloma is age-dependent, and it is increasing. It is a serious malignancy with various treatment options leading to a chronic disease state for many patients. Patients often experience pain, bone destruction, renal, and bone marrow failure. So we'll present a patient with a possible diagnosis of myeloma. This is a 58-year-old man who presented in the emergency room from a car accident in January 2010. He was found to have a fracture in the left femoral neck. He underwent a total hip replacement, and the biopsy of the removed bone showed infiltration by malignant plasma cells. Hypothesis. You are considering further tests to determine if he has early-stage diagnosis of multiple myeloma. The variable. The trifine bone biopsy showed 30% of infiltration by abnormal plasma cells. What is the effect of the variable on hypothesis? The diagnosis of multiple myeloma is reinforced by the finding that we have infiltration in the bone marrow, indicating that this is a generalized process. Subsequently, the patient underwent further laboratory examination. The serum electrophoresis and immunofixation revealed an IgG-kappa monoclonal protein at 3.13 grams per deciliter, an abnormal free light ratio, a moderately elevated beta-2 macroglobulin, preserved albumin. The patient had no anemia, no renal impairment, no hypercalcemia. Multiple myeloma is staged by estimating the myeloma tumor cell mass on the basis of the amount of monoclonal protein in the serum and the urine. Is this true or false? This is true. Further laboratory investigations in this patient with skeletal X-rays revealed multiple lytic lesions only in the skull. The patient had a small amount of proteinuria, and the urine electrophoresis showed free monoclonal kappa lambda chains. The IgG was elevated at 3.6, IgA and IgM was suppressed. He had a normal karyotype, and FISH test was performed, which did not reveal deletion 13q, 17p, or 414 translocation, indicating that this patient has a standard risk cytogenetics. So we have a patient with multiple myeloma, IgG-kappa, ISS2, and with no adverse cytogenetic features. You are considering treating this patient with lenalidomide and dexamethasone until progression. His multiple myeloma has been diagnosed at an early stage. What is the effect of a variable on hypothesis? The variable is reversing the hypothesis because this patient is not an elderly patient, and at this age one would consider a more intensive treatment, which will include high-dose therapy with stem cell support. In every patient with symptomatic multiple myeloma who is less than 65 years of age, we want to investigate therapeutic schemes with a cure in the horizon. Thus, we start with the induction therapy, and of course there is always a question which is the most appropriate induction regimen today. Subsequently, we proceed to stem cell collection, and also we want to know how to optimize stem cell collection. And then we administer high-dose therapy. The standard today is high-dose melphalan alone. However, there are questions whether other treatments may be beneficiary or whether we should use a single or a tandem transplant. After high-dose therapy, there is a question whether the patient should receive consolidation or maintenance. There has been several studies which have indicated that novel agents have improved the outcome of induction regimens in multiple myeloma. Several studies have compared the old gold standard, which was VAD, to combinations which include bortezomib with dexamethasone or bortezomib with thalidomide and dexamethasone, and all have indicated improved response rate and improved progression-free survival in favor of combinations which include bortezomib, dexamethasone, and possibly a third agent. These are data from the HOVON trial, which compared induction with VAD, high-dose melphalan supported by autologous stem cell transfusion, followed by thalidomide maintenance, versus PAD, which is a combination including bortezomib, doxorubicin, and dexamethasone, followed by high-dose therapy, followed by bortezomib maintenance. This study indicated that the PAD bortezomib strategy was better than the VAD thalidomide strategy as far as progression-free survival is concerned and also overall survival. Indeed, a recent meta-analysis which analyzed several phase 3 trials of bortezomib-containing induction regimens indicated that when bortezomib is included in the induction regimen, there is an increase in the complete response rate after induction. Furthermore, there is a positive impact in the overall survival of the patients. Thus, novel agents improve progression-free survival when used as induction before high-dose therapy. Bortezomib and dexamethasone should be part of the induction regimen, and today we use VTD, VCD, PAD, or sometimes a combination of bortezomib with lenalidomide and dexamethasone. Definitely, a 3-drug regimen is better than a 2-drug regimen. However, it is not clear whether we should prefer VTD versus VCD, and studies are ongoing to investigate this question. 4 cycles are considered the standard. However, maybe more treatment in responding patients could be evaluated. There are some indications that 4-drug regimens with the established agents that we have today are not better than 3-drug regimens but are associated with increased toxicity. However, in the future, with the new monoclonal antibodies which are emerging as active treatments in myeloma, this may change and we may see a 4-drug regimen will incorporate monoclonal antibodies. Our patient received induction therapy in January 2010 with VAD, 1 course of VAD. He was treated in a small center. The patient did not respond, and then he was referred to us. At that time, we changed treatment and we administered VTD for 4 courses. Induction was completed in May 2010, and the patient had achieved a partial response. The patient was scheduled to receive autologous stem cell transplant in September. However, in August, 1 month before starting stem cell transplantation, the patient experiences relapses with biochemical relapse. So what is the effect of variable hypothesis? This observation of the relapse now postponed the program of proceeding with high-dose therapy because the disease is not under control anymore. The patient received lenalidomide dexamethasone as salvage therapy for 6 courses. This was started in September 2010, and he achieved a partial response. In April 2011, stem cells were collected and the patient received high-dose melphalan supported by autologous stem cell transplantation. The patient achieved a partial response. Unfortunately, a few months later, in October 2011, the patient experiences a biochemical relapse. This is the course of the patient. He receives VAD without response for one course. Subsequently, the patient received VTD for 4 courses with response. However, this response was transient. The patient relapsed. He received lenalidomide and dexamethasone for 6 courses, and then subsequently he underwent high-dose therapy with autologous stem cell transplantation. Unfortunately, the benefit of this procedure was not lasting, and the patient experienced a biochemical relapse. In October 2011, the patient is experiencing a biochemical relapse with an increase in the monoclonal protein, and the patient does not meet the CRAB criteria. This data reinforced that the patient has a biochemical relapse. What is the optimal treatment for a patient in a biochemical relapse with short remission duration? Wait for a clinical relapse, go for a second transplantation, start lenalidomide dexamethasone again, since it seems that this was the most effective therapy until now for the patient, start pomalidomide dexamethasone, start calcifimab dexamethasone. I believe that the correct answer for this patient is to administer calcifimab and dexamethasone, and I will explain why. Biochemical relapse means an increase in the monoclonal protein without meeting the so-called CRAB criteria. Thus, the patient does not have any symptoms or signs related to the underlying myeloma. There is no anemia, no renal impairment, no increasing or new bone lesions, and no hypercalcemia. CRAB is the acronym for hypercalcemia, renal failure, anemia, and lytic bone lesions. Clinical relapse requires direct indicators of increasing disease and end organ dysfunction, such as development of new soft tissue plasmacytomas or bone lesions, a definite increase in the size of existing plasmacytomas or bone lesions, hypercalcemia, decrease in hemoglobin, and increase in serum creatinine. Obviously, the outcome of the patients with symptomatic and with asymptomatic relapse is completely different, as it is shown here. The survival for patients being diagnosed with asymptomatic relapse is significantly longer. When the patient is a candidate for treatment in the relapse or refractory setting, we have to take into consideration several variables. First of all, what has been the tolerance to prior therapies? Is the patient having pre-existing toxicities from prior therapies, such as peripheral neuropathies? Has the patient received high-dose therapy? What is the interval since the last therapy? Also, has the patient a high-risk cytogenetic features according to presence of 414 or 17p deletion? What is the age of the patient? Are there any comorbid conditions that will affect our choice to select treatment? What is the performance status of the patient? What are the available treatment options that we have? And this is a flow chart which indicates that for patients who relapse, one may consider to repeat the frontline treatment. Retreatment is feasible when there is a long remission achieved with the primary regimen and there are no accumulated toxicities from first-line therapies. However, switch drug class is the best option for the patient if the remission is short or when there are toxicities from prior lines of therapies. Of course, we have today a wide variety of novel agents and experimental agents to treat our patients. However, several patients with myeloma become refractory to both bortezomib and IMiDs, thalidomide and lenalidomide. The outcome of this patient is really poor. The expected event-free survival is approximately 5 months, and the expected overall survival is 9 months. Autologous stem cell transplantation at the relapse setting may be considered only in patients who have had a significant benefit from the first transplantation exceeding 18 months. Also, it is better to have sensitive disease after reinduction with a novel agent-based therapy. Salvage autologous transplant is not an option in our patient because he had only a very short benefit from this procedure. Calcifimab is a novel proteasome inhibitor which was approved in the United States for the treatment of patients with relapsed and relapse refractory myeloma which progressed during or within 60 days of completion of the last therapy. A large phase 2 trial, which included 266 patients, targeted patients with advanced and refractory myeloma who have received all 4 classes of approved therapies, including bortezomib, IMiDs, lenalidomide or thalidomide, alkylating agents, and anthracyclines. Calfizomib was used as monotherapy at a dose of 20 to 27 milligram IV per meter square on days 1, 2, 8, 9, 15, 16, for every 28 days. The primary endpoint was objective response rate, with secondary endpoints being duration of response, PFS, TTP, overall survival, and safety. These are the response rates which were induced in this study with single-agent bortezomib. 24% of the patients achieved a partial response or better, and an additional 13% of the patients achieved minor response for a clinical benefit rate of 37%. The duration of response for responding patients was 8.3 months. Progression-free survival for the whole group of patients was 3.7 months, and the median overall survival was 15.6 months. Calfizomib was well tolerated in these patients with advanced disease which have been heavily pretreated. Neutropenia and thrombocytopenia was seen in several patients, but it was severe in a minority of the patients, and more interestingly, the episodes of febrile neutropenia were very short. As far as non-hematologic toxicities were concerned, fatigue, nausea, dyspnea were seen in less than 5% of the patients. Very few patients experienced increase in their creatinine. More recently, the results of the FOCUS study were reported. FOCUS included patients with far advanced myeloma, refractory to many standard agents, with mandatory prior therapy with bortezomib, with immunomodulatory agents, with alkylating agents, with corticosteroids, refractory to the most recent regimen, with a creatinine clearance of more than 50 ml per minute and more than 30,000 platelets. The patients were randomized to receive single-agent calfizomib on days 1, 2, 8, 9, 15, and 16 of 28-day cycle. The first day was at 20 milligram and subsequently at 27 milligram per meter square. The control group consisted of corticosteroids, which could be prednisone or dexamethasone with optional cyclophosphamide. However, 95% of the patients received cyclophosphamide with steroids. Primary endpoint of the trial was overall survival, and as we can observe here, there was no difference in the overall survival of the patients, and the data indicated that the outcome of calfizomib compared to cyclophosphamide and prednisone was similar. However, one has to keep in mind that there was a comparison of a single-agent calfizomib versus a combination of cyclophosphamide and prednisone, and also several patients have not been previously exposed to cyclophosphamide. In a similar manner, the PFS was similar in both groups, at 3.7 months and 3.4 months. Further evaluation of calfizomib has been performed in combination with lenalidomide and low-dose dexamethasone in relapsed myeloma. A phase 2 trial which included heavily pretreated patients with relapsed or progressive myeloma after 1 to 3 prior lines of therapy without significant neuropathy and with adequate blood counts and creatinine clearance evaluated the combination of calfizomib with lenalidomide and low-dose dexamethasone at a 6-dose escalation cohorts, treatment given every 28 days. These are the dosing cohorts. From cohort 1 to cohort 6, calfizomib dose was increased from 15 milligram to 27 milligram. Lenalidomide dose was increased from 10 milligram to 25, and dexamethasone dose was constant. At the expansion cohort, patients were treated at full doses of calfizomib with lenalidomide and low-dose dexamethasone. Patient characteristics are shown here. The median number of prior regimens were 2. Patients were pretreated with bortezomib, 81%, with lenalidomide, 73%, with both bortezomib and lenalidomide in half of the patients, and also 44% of the patients had received thalidomide. Furthermore, one half of the patients had received prior transplant, and also 2/3 of the patients were treated with alkylating agents. Responses to full-dose calfizomib and lenalidomide dexamethasone, the so-called KRD regimen, is shown here. Overall, 78% of the patients responded, and for patients who had received only one prior therapy, 90% of those responded, and the median duration was not reached. Here we can see the efficacy of KRD in patients according to prior treatment with bortezomib to lenalidomide, and we can appreciate that even in patients who were lenalidomide refractory, responses occurred in 70%, and the PFS was 8 months. In patients who were lenalidomide naive, responses occurred in 80%, and the PFS was 28.7 months. This data formed the basis of the ASPIRE trial. This is a large trial which included patients with relapsed or progressive myeloma after 1 to 3 prior lines of therapies. The patients were stratified according to prior bortezomib, prior lenalidomide, and beta-2 macroglobulin levels. Patients were included with the condition that they were not refractory to lenalidomide. The standard arm consisted of lenalidomide and dexamethasone given until evidence of disease progression or unacceptable toxicity. The KRD arm consisted of calfizomib given at a dose of 27 mg per meter square on days 1, 2, 8, 9, 15, 16 every 28 days with lenalidomide and dexamethasone. After cycle 12, calfizomib was given on days 1, 2, 15, and 16, and after cycle 18, calfizomib was discontinued, and the patients continued with lenalidomide and dexamethasone. The main endpoint of the study was PFS, and the endpoint was met with a highly statistical and clinical significance. The median PFS for patients treated with lenalidomide dexamethasone was 17.6 months, and the median PFS for those treated with KRD was 26.3 months, and the hazard ratio was 0.69. These data are clinically very meaningful since we have an improvement of the PFS in excess of 8 months. Let's go back to our patient. The patient was included in the ASPIRE trial. He was randomized to the KRD regimen, and as you can appreciate here, he achieved an excellent response after KRD, which is lasting many months after the initial treatment. Thus, we had a patient who had short responses to induction therapy, a very limited benefit after high-dose therapy, but with the KRD regimen given as a third-line treatment, the patient is experiencing a significant clinical benefit. You are considering referring the patient to a cardiologist due to heart palpitations while he was taking treatment with calfizomib, and since his diagnosis 10 years ago, he just celebrated his 68th birthday. How this affects your decision? It reinforces your decision. Adverse events with calfizomib have been noted in a minority of patients. Among patients enrolled in phase 2 studies, 22% experienced what one may consider as one cardiac adverse event. The most serious reported cardiac adverse events was reported in 7.8% of patients and consisted of congestive heart failure. The most commonly adverse event reported with calfizomib is dyspnea. However, this is considered to be partly due to the fluids which are being administered before and after calfizomib infusion. Treatment at relapse influenced by patient disease and previous therapy. Distinction between biochemical and clinical relapse is necessary. Bortezomib and thalidomide have improved the outcome of patients with relapse disease, but now these agents are used as first-line therapies. Thus, we need to develop effective regimens that may overcome resistance associated with bortezomib and with IMiDs. Novel agents are helping to extend the time the patients live without progressing disease, and the novel agents to treat myeloma will require a balance of efficacy and safety and sequence regimens. Can we transform myeloma into a chronic manageable disease? I believe that today 70% of newly diagnosed symptomatic patients with multiple myeloma will have a chronic course. However, unfortunately, 30% of patients who have adverse features, especially adverse cytogenetic profile, will still have a short median survival not exceeding 3 years. Thank you very much.